Hi guys, this is Dr. Patil, and in today's video module we will be discussing about spondyloarthritis with special emphasis on ankylosing spondylosis. We will be discussing all other related peripheral spondyloarthritis conditions in subsequent videos. Okay. We will begin the session by understanding what do we mean by spondyloarthritis. Okay. Spondyloarthritis are a group of disorders that share certain clinical manifestations and they have a strong correlation with certain genetic associations, certain genetic factors. We guys know already what I'm talking about. Yes, they have a strong correlation with HLA-B27 and they do share some degree of pathogenic mechanisms, right? That is why they are clustered together and called as spondyloarthritis. Okay. Currently, these spondyloarthritis are classified based on the predominantly involved joint. What joint is more commonly affected or predominantly affected? Based on that, they are divided into two categories. Axial spondyloarthritis, the classical example for that is obviously ankylosing spondylitis, and peripheral spondyloarthritis, which includes psoriatic arthritis, reactive arthritis, and IBD associated arthritis. Right? These three are peripheral arthritis. There may be circumstances where they do not characteristically fit into these three. Then we will be calling them as undifferentiated. We will be calling them as undifferentiated peripheral arthritis. Undifferentiated peripheral spondyloarthritis. Okay. Similarly, there may be situations where there is ankylosing spondylitis-like picture, but patients may not have radiological evidence. In that case, we will be calling them as non-radiographic, right, or non-radiographic axial spondyloarthritis. This is when we generally follow conventionally done radio imaging like X-ray. But if you do more sensitive MRI, specific MRI sequences, you may be able to identify those radiological changes. Okay, so this is the latest classification from the ASAS. Okay, so this is something that I want you to remember. And I also want you to understand that there is significant overlap between these clinical features, right? From this image, it is very much evident that there is significant overlap between the clinical features of these disorders, right? And be aware that we have these two categories, right? Non-radiographic axial spondyloarthritis and undifferentiated peripheral spondyloarthritis. Okay. Now coming to some important features which are shared between the conditions which are clubbed under the umbrella of spondyloarthritis. Right? What are those? The first statement is gender. Male gender is more affected than females. Right? So when we are inside the rheumatology, we know that majority of the diseases are more common in females. So this is one exception. Right? Here, males are more affected than females. You talk about any of the conditions which come under the umbrella of the spondyloarthritis. At worst, they may have equal male and female prevalence, or else they have predominant male prevalence. There is no sub-entity under this heading which is more common in females. You talk about reactive arthritis, you talk about psoriatic arthritis, you talk about ankylosing spondylitis. Either the prevalence is equivalent or it is more common in males. Okay. Second characteristic finding across these disorders is that there is asymmetric lower limb involvement, that too mainly affecting the large joint like hip and knee joint, right? So there is peripheral joint involvement which is mainly affecting the lower limbs, mainly affecting the large joints. Okay. Then sacroiliitis is obviously the classical finding, especially when we talk about ankylosing spondylitis. This is also a shared manifestation. Then these patients have enthesitis, which is a characteristic finding. Enthesitis means inflammation of the insertion point of tendons, right? Insertion of tendon points, right? So they have enthesitis, they can develop dactylitis, which is also a shared manifestation. Then uveitis, especially anterior uveitis, in fact, is the most common extra-articular manifestation of this disease, right? Extra-articular manifestation of disorders which can be discussed under spondyloarthritis, right? Then one more feature you must know, in the past we used to call the disease as seronegative spondyloarthritis because RA factor used to be negative in them, right? So negativity of RA factor is also a shared manifestation. Psoriatic arthritis, reactive arthritis, ankylosing spondylosis, all of them have negative RA factor. And last but the most important is that there is a strong HLA association. See, for example, if I give you an example of ankylosing spondylosis, then we know that 88 to 90% of the patients who are diagnosed with AS are positive for HLA-B27. And then we also know that those who are positive for HLA-B27, right, 1 in 4 go on to develop ankylosing spondylosis in their lifetime. Okay, so these are the basic shared common manifestations between various disorders. Okay, now let us go back to the disease proper that we are supposed to discuss today, that is ankylosing spondylosis. Ankylosing spondylosis is the most common inflammatory disorder of the axial skeleton. Right, pay attention to my wordings. I say most common inflammatory disorder of the axial skeleton. So basically I am talking about an inflammatory arthritis which is affecting the axial skeleton. So these patients will have all the characteristic manifestations of inflammatory arthritis in the form of early morning stiffness lasting for at least more than 30 minutes. Most cases it is going to last for more than 45 minutes to 1 hour, right? And the joint pain which is worse in the morning and gets better as the day progresses. The pain which is worse when it is lying idle, and pain which is better on movement of joints, right? Pain which is better on joint movement or exercise, right? That is the characteristic of inflammatory arthritis. So that holds good here also. So if you're talking about axial skeleton, and these patients may have the low back pain and the stiffness of the spine which is more in the morning, and as day progresses, as they put the spine into action, it gets better, right? That is the characteristic thing. Now then the second thing I want you to remember is, I call it as a rule of 2, not exactly rule of 2, but I will call it as rule of 2 for the sake of remembering. That is about the prevalence of ankylosing spondylitis, right? The rule of 2. What does it say? 0.2% of general population, 0.2% of general population, 2% of HLA-B27 positive population, and 20% of the HLA-B27 positive population which has a family member diagnosed with ankylosing spondylosis have ankylosing spondylitis, right? 0.2% of general population, 2% of HLA-B27 population, and 20% of those who have HLA-B27 positivity and a family member who has been diagnosed with AS, right? They have ankylosing spondylitis. So this goes on to talk about the prevalence of the disease. Obviously, we already know the shared feature. Males are going to be more affected than females in the ratio of 1.3:1 roughly. Okay, 3:1. That is the ratio. Now, coming to clinical features of ankylosing spondylosis, right? Usually, the age of onset of symptoms is young adulthood, right? Young adulthood is the age of onset. The mean age of onset of symptoms is around 25 years, right? And the diagnosis is never considered if the onset is after 45 years. Right? So the mean age of onset of symptoms is 25 years, and the maximum acceptable age for the onset of symptoms is 45 years. So if someone presents with chronic low backache after 45 years, don't think of the diagnosis. Like when they present, the onset of symptoms is after 45 years, don't think of the diagnosis of ankylosing spondylitis. And there may be other possible diagnosis, right? So these 2 points to note. Usually the symptom onset is young adulthood, mean is 25 years, and the maximum age where you can confidently diagnose is when the patient is under 45 years. More than 45 years at the time of onset of symptom goes against the diagnosis of ankylosing spondylitis. Okay. Now the presenting complaint, as we know already, is going to be the low back ache, right? And it has to be chronic. It should be present for at least 3 months duration, right? And because it is an inflammatory arthritis, yes, as expected, patient is going to have early morning stiffness lasting for more than 30 minutes. Other than that, patients may have nocturnal low back pain. Okay. Now, whenever we talk about nocturnal pain or nocturnal symptoms, basically it is a pointer towards an organic disease. Right? It goes on to say that this is not something benign or this is not something functional. Right? If pain is awakening somebody in the middle of the night, probably it has to have an organic and a significant cause, right? So these patients do experience nocturnal low back pain. Okay. And we know that it is an inflammatory disorder, so pain may be better on exercise, right? So these are the clinical features when we talk about the ankylosing spondylitis, right? Apart from the axial skeletal involvement, we know that there may be involvement of the peripheral joints. So peripheral joint involvement will be in the form of involvement of the lower limb joints more than upper limb, and involvement of large joints more than small joints. Okay. And very often you may find that patients have history of current, ongoing or past history of tendinitis or heel pain, right? Heel pain should be taken as a pointer towards plantar fasciitis, and this goes on to say that patients might be having enthesitis, right? And we have already discussed this is one of the common shared manifestation of spondyloarthritis, right? Having enthesitis, tendon insertion point inflammation, right? So these are the clinical manifestations. If patient is having a long-standing ankylosing spondylitis, he may develop a forward stooped posture, like you can see in the image here, right? This can be assessed by doing a chin brow to vertical angle calculation, right? You do a vertical line and then along the chin and brow you make a line. If it is 30° plus, that goes on to say that patient has developed a forward stooped posture, right? If there is normal posture, then this degree will be 0 because they run parallel lines, right? When you do a chin brow line and a vertical line, then you will have a parallel line, so you don't get any angle there, right? Okay, now coming to extra-articular manifestations. Good number of these patients have extra-articular manifestations, and from the MCQ perspective, they can ask you which of the following is the most common extra-articular manifestation of axial spondyloarthritis or generally spondyloarthritis or specifically ankylosing spondylitis. For all of them, the right answer is acute anterior uveitis, right? Anterior uveitis is the most common extra-articular manifestation seen in up to 40% of patients, right? Usually, it is a unilateral anterior uveitis presenting in the form of pain, photophobia, and lacrimation, right? And recurrence is quite known to occur. Usually, it is unilateral presenting in the form of pain, photophobia, or lacrimation. And recurrence is common, and recurrence is known to occur in the opposite eye. Like you have been diagnosed as having acute anterior uveitis in one eye, you treat them with the topical steroids or if required systemic steroids, and then it recurs on the opposite eye, right? So recurrence is known, and recurrence is usually known to affect the unaffected eye. Okay, that is about the first and the most common extra-articular manifestation. Other than that, yes, patients can develop aortitis and it can go on to cause aortic regurgitation, right? That is also known extra-articular manifestation. Patients can develop conduction defects also, and it is not uncommon or it is not surprising to see these patients presenting with third-degree heart block, right? They can develop conduction defects. Third-degree heart blocks are also known to occur. Okay. Then another important point I want you to note is that these patients have a tendency to develop IBD. Right? If you do biopsies randomly, you will notice that 60% of the patients have asymptomatic mucosal lesions involving terminal ileum and proximal colon, which have characteristic pathophysiological appearance or features of inflammatory bowel disease, but they don't have evident clinical symptoms, right? This we see in 60% of the patients. But some of them, like roughly around 10% of those patients, go on to develop inflammatory bowel disease in the later part of the illness. Right? We already have an entity called IBD associated spondyloarthritis, but when you have diagnosed ankylosing spondylosis, there is good chances that you may diagnose IBD in those patients in the later part of the illness, right? Okay. The last two extra articular manifestations that you should remember is about the kidneys. It can cause IgA nephropathy and secondary renal amyloidosis, right? So these are the extra articular manifestations which are important from the perspective of exams. Okay. Now coming to the physical examination. Right. So now we know the articular manifestations, we know extra articular manifestations. So you have started suspecting that patient may be having ankylosing spondylosis. So we have to examine physically and prove that, because we are talking about axial skeleton involvement, and most important thing is to document that clinically and radiologically document that patient has sacroiliitis and has involvement of the spine or axial skeleton, right? So we have to prove that there is reduced spine mobility. For that, we do a famous test, which is known as Schober's test, right? A very famous test. We are very much aware of it from the undergraduate days itself, right? Schober's test. That is what we do for demonstration of restricted joint mobility. And for sacroiliitis, we can demonstrate that there is joint line tenderness, and we can do these two maneuvers. Fabier test in itself is a mnemonic, we will discuss about it, and Geislin maneuver, right? Fabier test and Geislin maneuver. We will see them one by one. Okay, now this is what we call as Schober's test, right? This is what we call as Schober's test. Right? As I told you, this is done to assess the spine mobility, right? Now what do we do in this test? we basically draw a line on the patient's back marking the L1 spinous process, right? L1 spinous process, and we will draw one more line 10 centimeters cephalad, right, towards the head, and we ask the patient to bend forward at his best capabilities, and then we see what is the distance between these two lines that we had drawn. To start with, that was 10 centimeter. If the person has normal spine mobility, it should become more than 15 centimeter, right? If it has become more than 15 centimeters, then there is a normal spine mobility, right? 10 centimeter has increased by 5 centimeters, going to become 15 centimeters. If it is less than 15 centimeters, you can say there is reduced spine mobility. One of the important differential in that case would be ankylosing spondylitis, right? Then we also have this modified Schauber's test, right? That is known as modified Schauber's test. A little bit modification of the same test. Procedure remains same, right? Modified Schauber's test. Procedure remains same. All the change that we do is basically we draw one more line 5 centimeter below the L1 spinous process. So we have identified L1 spinous process. We have drawn one line 10 centimeter above it and one line 5 centimeter below it. So now what length we have? We have 15 centimeters, right? We have a length of 15 centimeters, and same like the conventional Schauber test, we ask the patient to bend forward, and we are again expecting a 5 centimeter increase in this distance, right? So this 15 centimeters should become 20 centimeters. So if it is less than 20 centimeters, that goes on to say that there is reduced spine mobility. Okay, so we can do that also. So in case of modified Schauber's test, 15 centimeters was the starting point, and we wanted it to become 20 centimeters. If it has not become more than 20 centimeters, that means there is reduced spine mobility. Okay, this is about Schauber's test. Now coming to the next test that we were talking about, right? So Schauber test is for mobility. Now the next two tests we are going to discuss is for clinical documentation of sacroiliitis, right? What do we do in this? First test is Fabier's test, right? Fabier's test in itself is a mnemonic, right? Which goes on to say that what we are doing to hip is what is summarized in the test, right? We are basically causing flexion of the hip, then abduction, external rotation, and then finally extension of the hip, right? This puts the patient into figure of 4 position, right? If you look at this, it looks like 4, right? So this is also known as figure of 4 test, another name for this, and this is famously known as Patrick's test. Fabier is basically a mnemonic, right? The real name of the test is Patrick test. Orthopedics people would be calling it as Patrick test, right? So we put the patient on a flat surface or on examination table, right, in a supine position. Then we cause flexion of the hip and knee to put it on the ankle to go on the opposite knee joint, right? And then we are also causing a little bit of abduction and external rotation, and finally by applying pressure, right, we are causing extension at the sacroiliac joint, right? We are putting pressure on the opposite hip as well as the examination limb, and we are creating extension at the sacroiliac joint. If there is sacroiliitis, that would manifest in the form of pain, right? Pain in the sacroiliac region. The other test we can do, or other manual, is a Geislin maneuver or Geislin test. What do we do in this? In this also we are making patient lie down on a flat surface or an examination table, and we bring him to the edge of the table like you can see in this image, and we make him hang one limb to hang down from the edge of the table, with the emphasis that the examiner would be applying pressure on the knee joint so that the examination side hip is extended, in fact overextended. On the other hand, examiner is folding the knee of the opposite side and pressurizing or putting pressure in the cephalad direction so that the opposite hip is flexed, right? It is overflexed. This kind of stretches or puts pressure or strain on the sacroiliac joint, and they should trigger pain if there is sacroiliitis, right? So these two maneuvers to note its utility: Fabier's maneuver or Fabier's test or Patrick test or figure of 4 test, on Geislin maneuver or test. Okay, so that is about the physical examination. Now coming to imaging findings. So the most commonly performed image is basically an X-ray, right? So we do a X-ray of the pelvis and hip joint AP view. That is the most commonly performed imaging view, right? Why are we covering the hip? I have already told you that these are characterized by also peripheral joint involvement, where lower limb is more affected than upper limb, and in the lower limb it is mainly large joints, hip and knee joints, right? So it is not uncommon to see at the time of diagnosis itself patient having sacroiliitis as well as hip arthritis, right? So that is why we are doing a pelvis x-ray covering the hip joint. Okay, now having bilateral sacroiliitis which is symmetric is the hallmark. Having bilateral symmetric sacroiliitis is the hallmark of ankylosing spondylitis, right? It can be seen in any of the spondyloarthritis condition, and it must be seen in patients with ankylosing spondylitis. Okay, so we should know the X-ray view, we should know about the presence of sacroiliitis, and we should also know about the grading of sacroiliitis on X-ray. Why we should know? Because its utility we will discuss when we go on to discuss the classification criteria. So the grading includes 4 grades. Grade 0 is obviously normal. Grade 1 is where you have a suspicion about sacroiliitis. Grade 2 is where you see sclerosis, mainly subchondral sclerosis and some degree of joint erosions, right? So when there is sclerosis and some degree of joint erosions, we call it as grade 2. This is basically New York grading, okay? And when there is severe erosions, right? When there are severe erosions, joint space widening and some ankylosis. So initially there may be joint space widening, which we call as pseudo widening, okay? And then later on the joint starts getting fused, right? That is what we call as ankylosis, right? That is where the name ankylosing spondylitis comes from, right? So in grade 3 there may be severe erosions, joint space widening and some degree of ankylosis, right? Not fully ankylosed or not fully fused joint, some degree, then it is grade 3. When it is completely ankylosed, that is called as grade 4, right? That is called as grade 4, right? You can go through this image and tell me which grade it belongs to, right? Let me try to show you, right? Let me draw your attention to this area. I think you guys can appreciate that there is a joint space widening, right? And there may be some areas where there is fusion, right? So there is joint space widening and there is some degree of ankylosis in this X-ray, right? Sacroiliac joint is what I am talking about. So this obviously is a grade 3 sacroiliitis, right? Sacroiliitis. It's a grade 3 sacroiliitis X-ray. If you cannot really distinguish the joint line at all, right, then that means there is complete fusion or complete ankylosis. That is grade 4. Okay. Now coming to imaging of the vertebrae. So far we spoke about the sacroiliatic joint, right? Sacroilious joint. Now coming to imaging of the vertebrae. Vertebral involvement is also expected, right? So what do we see? We see some important named signs, right? The first named sign we should know is shiny corners, which is also known as Romanus sign or Romanus sign. Okay. What is shiny corner? If you look at this image, you can appreciate the corners are kind of shiny, right? This is what is known as Romanus sign, right? This is known as Romanus sign. So this is one of the named sign that can be asked as an MCQ. Romanus sign or shiny corner sign on vertebral X-ray or CT is seen in which of the following condition? Ankylosing spondylitis. Okay. The second thing is squared vertebrae. Squared vertebrae is also a radiological sign seen in ankylosing spondylitis. You may ask me, sir, what is squared vertebrae? Look at this image, right? Do you appreciate that vertebrae look like squares? Those who want to say that, sir, every vertebrae kind of looks like square, look at the anterior border, right? Normally we see some degree of concavity of the anterior border, right? There is some degree of concavity that we can appreciate. But look at the two images that are being pointed here, right? These two surfaces. You can clearly note that the anterior concavity is lost, right? Concavity or convexity, from whichever way you want to say it, right? That is lost, right? They kind of assume more specific like a squared look, right? That is why they are called as squared vertebrae. So squared vertebrae are seen in ankylosing spondylitis. Okay. Then the third radiological finding we can anticipate is to see syndesmophytes. Okay. What are syndesmophytes? These are calcification of longitudinal ligaments. So there are ligaments running longitudinally. If they are calcified, then we call them as syndesmophytes. And if such a calcification process, right, when they fuse with adjacent vertebral bodies, you can see in this image, right, these longitudinal running ligaments which are calcified, they are also leading to fusion of adjacent vertebral bodies. Right? They are leading to fusion of adjacent vertebral bodies. Then we call them as bridging syndesmophytes, which are also characteristic of AS. Right? Bridging syndesmophytes, right? Which are bridging the adjacent vertebral bodies. Right? These are not osteophytes; they are called as syndesmophytes. Okay, osteophytes are basically bony outgrowths, extra bony growths. Right? Okay. Now that was about the X-ray or CT findings. Okay. Now it has its own limitation because it cannot detect the changes early, right? Only when gross morphological changes are evident, we can identify based on the X-ray, right? So if you want to diagnose early, you have to go with MRI. MRI is most useful investigation for early diagnosis of sacroiliitis, right? And for that, what is the earliest sign? The earliest MRI sign is basically bone marrow edema, and this is also the most specific MRI sign for ankylosing spondylosis, right? So this is the earliest, also most specific also for AS. But to identify this bone marrow edema, obviously there will be evidence of inflammation and all, MRI evidence, but that is not very specific because it may be getting confused with other possible entities. So bone marrow edema is something which is relatively specific to ankylosing spondylosis. But to identify this bone marrow edema, we cannot rely on the conventional MRI sequences which are done for routine evaluation of low backache, right? You routinely do an MRI for low backache. Well, those are not going to be very much useful. Right? What is going to be useful is a sequence known as STIR sequence, which stands for short tau inverse recovery, right? Tau inverse recovery sequence, right? So these images can detect the bone marrow edema, or you have to go with the T2 weighted images with fat absorption sequence MRI, right? So only these two can be helpful: STIR sequence imaging or T2 with fat absorption sequence imaging of MRI, right? Okay, that is about the investigation. Now coming to laboratory tests, yes, you can definitely do a HLA B27, especially when the radiological evidence of sacroiliitis is missing. Otherwise, if you look at the classification criteria later on, you will understand that if you have radiological evidence of sacroiliitis, which is like very typical of the ankylosing spondylitis, and you have spondyloarthritic feature, at least one of them, that is kind of more than enough to classify the case as ankylosing spondylitis, right? But in the absence of the radiological evidence, you might have to go for the HLA B27 testing. I have already told you that 88 to 90%, and according to some studies, more higher number of patients are positive. Patients of ankylosing spondylosis are positive for HLA B27 variant, right? And I have also told you that 25% of those patients who have HLA B27 asymptomatic later go on to develop ankylosing spondylitis or some other forms of spondyloarthritis. Okay. Now coming to differential diagnosis, right? There are some important differential diagnoses we should know, right? I am listing two important ones. The first one is DISH, right? Which stands for diffuse idiopathic skeletal hyperostosis. This is basically a disorder of the elderly where there is again calcification of the longitudinal ligaments, and that gives rise to certain radiological features which might look or mimic like the ankylosing spondylosis radiologically. Clinically, this is not going to be very confusing because patients with DISH, I have told you already that this is a disorder of elderly, so they never present before the age of 45 years. And for ankylosing spondylosis, the diagnostic criteria say that you should consider when the onset of symptoms is before 45 years, right? I have already made that point very, very clear. Mean age of presentation is 25 years. Maximum we can think of is at the onset of symptoms, the age should be less than 45 years. More than 45 years, we're not thinking of the diagnosis of ankylosing spondylitis, right? But this usually presents after 45 years. DISH presents after 45 years. So clinically, it is not very difficult to distinguish. Another thing, when you do imaging, you can notice is that there may be longitudinal ligament calcification, which radiologically manifests with a radiological sign known as flowing wax sign, right? Flowing wax sign or flowing candle wax sign. That is a radiological sign which is associated with DISH. But you can clearly notice that there is no involvement of sacroiliac joint, right? So non-involvement of sacroiliac joint goes in favor of DISH. If it is involved, yes, we would be thinking of ankylosing spondylitis, right? Another differential diagnosis is SAPO syndrome, which stands for synovitis, acne, pustulosis, hyperostosis, and osteomyelitis, which can also be easily differentiated from the fact that there is involvement of acne and pustulosis, right? That skin involvement kind of helps us to distinguish between SAPO and ankylosing spondylitis. Okay, that is about differential diagnosis. Now coming to diagnosis. The diagnosis, obviously diagnosis is based on the clinical context, but most of us have a tendency to follow the classification criteria itself for our day-to-day practice, right? So ASAS classification criteria, which is currently followed, even the basic classification that we spoke about, peripheral versus the axial spondyloarthritis, that broad classification also stems from the ASAS itself. So the classification criteria put forth by ASAS for axial spondyloarthritis basically goes on to say that patient should have at least 3 months history of back pain and the age at onset should be less than 45 years, right? So we know the importance of this age at onset now. The age at onset should be less than 45 years. So in these patients, like patients less than 45 years at the time of the onset of symptoms, presenting with 3 months or more than 3 months of low back pain or back pain in general, right? We would be considering the possibility of ankylosing spondylosis or axial spondyloarthritis in them if they have the evidence of sacroiliitis on imaging. Either you are going with MRI or X-ray. There is a evidence of sacroiliitis on imaging. In such patients, if they have one feature or more than one feature of spondyloarthritis, we need at least one spondyloarthritis features, right? Those features are listed here. What are the features? Having inflammatory back pain. So we already know the characteristics of inflammatory back pain, right? Patient presenting with early morning stiffness lasting for more than 30 minutes. Pain which is better on exercise, worse on idleness. Yes, that is the typical story, right? Then patients having peripheral arthritis, mainly affecting the lower limbs, mainly affecting the large joints, or they having enthesitis, especially the heel enthesitis. Heel pain is a very common complaint in them, right? Or having anterior uveitis or dactylitis, having skin manifestations in the form of psoriasis, IBD, and also history of good response to NSAID. So if they are already presented with 3 months or more than 3 months complaint of low back pain, if they tell that I really feel really good with conventional NSAIDs, that should be counted as one of the spondyloarthritis features, because the mainstay of treatment, when we talk about treatment, we will be discussing about it, is NSAIDs, right? And if there is family history of spondyloarthritis, that is also counted as the spondyloarthritis feature, or HLA-B27 positivity. And also remember that CRP and ESR may be raised. I don't say that it is always raised, but it may be raised in substantial number of patients. So that can also be counted as a spondyloarthritis feature. Okay. Now talking about this sacroiliitis on imaging, right? So I told you MRI or X-ray can be done. So if MRI finding is highly suggestive of sacroiliitis, we know what is the specific sign, right? Bone marrow edema around the sacroiliac region, right? Bone marrow edema. Obviously, we are going with that STIR sequence or T2 with the fat imaging sequence, right? Fat absorption imaging sequence. Yeah. In that case, it is highly suggestive of sacroiliitis. So you say that there is evidence of sacroiliitis on imaging. Or if you are going by X-ray, right? If you are going by X-ray, then it should be a definite radiographic sacroiliitis according to modified New York criteria. Like what modified New York criteria says is, it will be considered as definitive evidence of sacroiliitis if it is grade 2 to 4 when it is bilateral, right? 2 to 4 when it is bilateral, because bilaterality and symmetry is what we are anticipating or what we are expecting, right? If it is unilateral, then it should be grade 3 or 4, right? Bilateral grade 2 is acceptable, but unilateral grade 2 is not in favor. So it should be grade 3 or 4 when it is unilateral sacroiliitis. That qualifies to be called as definite radiographic evidence of sacroiliitis according to modified New York criteria. So we have already discussed the grading, right? So grade 3 means what? We are expecting some ankylosis and joint space widening. Grade 4 means we are expecting complete ankylosis, right? Okay. That is when we have a radiographic evidence of sacroiliitis. If there is no radiographic evidence, right, what we can do? We can go with HLA-B27, right? We can go with HLA-B27. But in that case, we need 2 or more than 2 spondyloarthritis features. So among these, we need 2 or more than 2. If it is definitive radiological evidence, then we need only one of them to be present. But when we talk about relying on the HLA instead of radiological evidence, we need 2 of the spondyloarthritis features to classify the case as axial spondyloarthritis according to ASAS classification criteria. Okay, so age is something that is very, very important for us to note before we move on. Okay, now coming to management of ankylosing spondylitis, right? Exercise is an important part of the prescription because this is an inflammatory arthritis and exercise makes them feel good, right? Exercise improves their pain and it is helpful, right? So the stiffness of the spine gets better if you put into exercise. So we should recommend them for back extension, which is very, very helpful. And other than that, swimming is an exercise modality which puts the axial skeleton into action very well, right? So we should recommend them to do back extension exercises and swimming. Okay. Then when it comes to drug therapy, yes, obviously NSAIDs are the mainstay of treatment, right? I have made it clear here. NSAIDs are the mainstay of treatment. Preferably we use potent NSAIDs like indomethacin or maybe naproxen. Most of the patients are very happy with that. Cardiac diseases are not a concern, or cardiovascular mortality is not a concern, and patient is experiencing the unconventional side effects of NSAIDs, like is not able to tolerate it well, there is gastritis or other limitations. In those cases, yes, you can also use COX-2 inhibitors, right? COX-2 inhibitors can also be used. When NSAIDs are not helping at their reasonably well tolerated doses, you may consider adding the disease modifying agent, right? Disease modifying agents include sulfasalazine. That is the most commonly used disease modifying agent in case of axial spondyloarthritis. But the truth is they have a limited benefit when it comes to ankylosing spondylosis, but they are more useful when we talk about peripheral spondyloarthritis. Even in patients with ankylosing spondylitis, they give a better result on the peripheral joints than the sacroiliac joint and the axial skeleton. If at all we are using, we have to use at around a dose of 2 to 3 grams per day, right? The other disease modifying agent that can be used is methotrexate. Methotrexate can be used also, right, as a disease modifying agent when NSAIDs are not giving the adequate response. Generally, when we start NSAIDs, we treat them for at least 3 months to decide on the response, and at the end of 3 months, if you are not happy, if the patient is not happy, or when we follow the conventional scoring systems for disease activity, the commonly followed scoring system is basically BART, ankylosing spondylosis disease activity index, or what we call as BASDAI, right? BART, ankylosing spondylosis disease activity index, right? BASDAI. So if this score is high, usually more than 4 can be considered out of 10, more than 4 can be considered as significant activity. In those cases, yes, from NSAIDs you can add a disease modifying agent, most commonly sulfasalazine. With this also, if you're not getting the disease under control, disease activity still remains high, in that case, yes, you may go to the next level where we will be using the anti-TNF alpha therapy, right? We would be considering anti-TNF alpha therapy. Where is it indicated? It is indicated in patients with ankylosing spondylosis where 3 months of NSAID therapy has not achieved good result. 3 months of NSAID therapy has not achieved good relief, you may consider them. And it can also be considered in ankylosing spondylosis patients with peripheral arthritis who are refractory to sulfasalazine. Right? I have already told you, right? The sulfasalazine works good for peripheral spondyloarthritis, right? So if peripheral complaints are the dominant manifestations, or you are mainly bothered about their peripheral joint complaint and you are okay to treat with their axial skeletal symptoms, then you would be preferably trying the sulfasalazine. If sulfasalazine is not helping, then you are going with the anti-TNF alpha therapy. Right? I don't think I should be listing the examples of anti-TNF alpha drugs. You are all familiar with the infliximab, golimumab, adalimumab, etanercept. All of them you are very much aware of, right? So that is our go-to drug, third line agent. So first line NSAIDs, they are the mainstay of treatment, backbone of the management of the back problem. If they are not helping, even after 3 months, you may think of the step up. Sulfasalazine would be the choice if the peripheral joint symptoms are something that are bothering the patient, or if it is primarily the axial skeleton or peripheral joint symptoms are negligible. In that case, you can directly step to the TNF alpha therapy, right? Sulfasalazine is not going to be very helpful for axial skeletal symptoms. Okay. If they are also not helpful, TNF alpha therapy is deemed failed. In those cases, you can go higher up. You can use ustekinumab which is an anti-interleukin 12, interleukin 23 monoclonal antibody, and another is secukinumab, which is an anti-interleukin 12 alpha or anti-IL-17, anti-IL-17A or anti-IL-17 alpha monoclonal antibody, right? These are kind of reserved drugs. These are usually considered in patients where TNF alpha therapy has failed, right? Failed TNF alpha therapy, you may consider using ustekinumab or secukinumab. Okay, so I hope the approach is clear. Now coming to the regimen and dosing of these drugs, I personally don't like examiners asking MCQs about the doses. Right now, today we are in the era where you can get information easily on your palm. I don't like them asking these memory-based questions, but nonetheless, they have a tendency to ask MCQs about it. So we will discuss a little bit about it. Okay, so I have made a simple table for you to remember the dose and regimen. That first drug is infliximab, which is usually administered IV. Right? Among the drugs that I have listed, infliximab is the only one which is administered IV. The usual dose is 5 milligrams per kg, and it is given on the day 0 when you decide to give it. Then you repeat the dose after 2 weeks. You repeat another dose after 6 weeks, 3 doses, and then after that we would be giving the infliximab at 8 weekly intervals, right? Every 8 weeks we will be giving them 1 dose, right? Calculated at 5 milligrams per kg. So on day 0, on the day we decide to start, then we are giving after 2 weeks, then we are giving after 6 weeks. After that, every 8 weeks we are giving 1 cycle of infliximab. Okay, if you are considering etanercept, right? Etanercept we would be giving subcutaneous, like all other drugs that we're going to discuss now will be subcutaneous. The dose is 50 milligrams and it is given weekly. If we talk about adalimumab, that is also subcutaneous. The dose is 40 milligrams and that is given bi-weekly, once in 2 weeks. Right? Then, if we talk about golimumab, this is also subcutaneous, 50 to 100 milligrams, and this is given every 4 weeks, just like certolizumab, right? Certolizumab pegol subcutaneous 400 milligrams, again every 4 weeks. And the last drug I am talking about is secukinumab, which is also given as a subcutaneous injection at 150 milligrams, but initially it is given weekly for 4 weeks. So first 4 weeks we give weekly. After that we shift to a 4 weekly regimen, right? So first 4 weeks we give weekly subcutaneous injections, 150 milligrams, and those first 4 doses are completed. After that, once a month we keep giving, right? 4 weekly. That is about the dosing of these drugs. Okay, so hope I have summarized the essential points that you need to know. As long as you are not preparing for Central Institute Rheumatology branch, I think this much of information is sufficient to crack the MCQs that routinely appear. What is most important according to me are the radiological named signs which are frequently asked. Especially I have seen some MCQs coming from the Sri Chitra Tirunal in the past. They become relevant for NEET SS also. And the management of it. Right? Okay guys, so we will wind up now. Right? Let me connect to you on another video. Thank you.